Chapter 10, Pleural, Pericardial, and Peritoneal Fluid Analysis, or also known as serous body fluids. So here is a diagram that outlines the serous body cavities. So the abdominal cavity, the lungs, and the heart are all surrounded by a very thin membrane in addition to a body cavity wall. So this space is filled with fluid, and it lies between the membrane that covers the organs, which is called the visceral membrane, as well as one that lines a body wall, which is called the parietal membrane. And from these cavities, they're separated, named for the organs that it encloses. So for example, the lungs are surrounded by a pleural cavity, the heart, a pericardial cavity, and the abdominal organs, the peritoneal cavity. In each visceral and parietal membrane, you have a small amount of fluid which really serves as a lubricant between those membranes in order to protect the organs as well as have them move freely. This fluid is maintained through plasma ultrafiltration and absorbed through the visceral membrane. The name released serous fluid is just general to describe that they are an ultrafiltrate of plasma and therefore have a similar complication or composition to serum. The concentration of fluid within the serous membranes is constantly changing or dynamic. It's really controlled by 4 factors, meaning it's controlled by either the permeability of capillaries in the parietal membrane, hydrostatic pressure in these capillaries, oncotic pressure produced by plasma proteins, or the absorption of fluid by the lymphatic system. So oncotic pressure is just a form of osmotic pressure exerted by proteins in either the blood plasma or in the interstitial fluids, whereas hydrostatic pressure is a force generated by the pressure of these fluids on the capillary walls, either by blood plasma or by the interstitial fluid. So overall, hydrostatic pressure, which is really blood pressure, forces the ultrafiltrate from plasma to form within the cavity, but at the same time, plasma proteins in the capillaries produce an oncotic pressure, which is an opposing kind of pressure for this filtration. And because of its permeability, it regulates how quickly and how much ultrafiltrate can form and what proteins are composed of it. What if something goes wrong? What if you have an increased permeability of the endothelium, which causes more proteins from the blood into the fluid? When this happens, now you have a rich protein fluid which further enhances the movement of more fluid into the cavity. So when you have an accumulation of fluid or excess fluid, this is called an effusion, which is abnormal accumulation of body fluids in those cavities, which is indicating some kind of pathological process or that something's wrong in the patient. Now with these types of specimens you will get in the lab, you will have to know which anatomical site they came from, the procedure for each site, and the fluids name obtained within each of the categories. So we've talked about CSF before, and you know that the spinal cord produces CSF fluid due to a lumbar puncture or spinal tap. And we'll talk about synovial or joint types of fluids in the next chapter. Let's focus on the serous fluids here, the pleural, pericardial, and peritoneal. So when we're talking about paracentesis, this just refers to generally puncturing the cavity for an aspiration of fluid. So anatomically, you have to describe the body cavity it is coming from. So if you're taking pleural cavity, for example, okay, this is the lung cavity. The procedure or surgical process of puncturing the chest wall is called a thoracentesis. And the collection of the fluid would be pleural fluid. Similarly to the pericardial cavity, which contains the heart, you are performing a pericardial aspiration or pericardiocentesis from that cavity wall, producing pericardial fluid. Now, when we talk about the abdominal wall or the peritoneal cavity, we're talking about a paracentesis or abdominal paracentesis from that cavity, producing peritoneal fluid or ascites fluid. Now, ascites is a term to describe an effusion specifically from that category, and it's another name for peritoneal fluid. Collection for serous fluids is an invasive surgical procedure performed by a physician using sterile tubes. Now, unlike CSF fluids, serous fluids can accumulate in great numbers and great volume. I have seen an ascites fluid come in with 20 liters of accumulation. So that is more than needed for the laboratory, and they will only send up a possible sampling for what is needed for analysis. So usually they're put into anticoagulant tubes for microscopic examination to prevent any kind of clotting of the specimen, and for chemistry types of specimens, you want a non-anticoagulant type of tube. These specimens must remain at room temperature and tested immediately because degradation starts to happen. Now, refrigeration is definitely avoided if you want to do some microbiology testing, because refrigeration affects the proliferation of microbes and can also kill them. Now, from these fluids, a blood sample will be collected in order to compare the chemical composition of that effusion with that of the patient's plasma, which kind of classifies them into the type of abnormality it is. Are the types of fluids that could be removed from the serous fluid cavity. So effusions are classified into transudates and exudates. A transudate is a fluid accumulation from some kind of systemic disease, whereby an exudate is a fluid accumulation from some kind of pathological state of the area. So when we look at these types of specimens, we have to see their characteristics. So a transudate is non-inflammatory. The specimen typically looks clear or very pale yellow. There are very few cells here in some degree, whereas exudates are usually due to some kind of inflammatory process where their specimens usually look cloudy, yellow, or bloody. And in these instances, you have very many cells, and the joints or spaces are also very inflamed. Now, it's very important to classify these types of effusions because it helps physicians identify what's going on with the patient. So in table 10.3, you have the effusion, the type of the abnormality, and the mechanism or cause, and what types of conditions it can be seen. So from the pleural and peritoneal categories, for a transudate, this is due to a systemic breakdown due to congestive heart failure if it's in the heart, or other types of things, liver because it's in the abdominal category, or some kind of kidney problem leading to an excess of fluid. So that is classified as a transudate and is usually due to a decrease from the blood pressure as well as that opposing oncotic pressure force. So with the exudates in that category, you have an increased permeability leading to the increase in fluid accumulation with a decrease of absorption. So here you're seeing infections such as bacterial, viral, fungal, in any of tumors as well. And you can definitely see the difference physically in those changes. So these fluids, again, will be examined on their physical characteristics as well as their microscopic characteristics and chemical characteristics. Pericardial fluids are not really classified into transudates or exudates, but they do have an increased capillary permeability, which is caused by infections, tumors, or certain kinds of hemorrhages or diseases. About the appearance and what that appearance may mean to a physician. So if you're getting a cloudy paracentesis fluid within the lab, you would often indicate that there is a large number of leukocytes, cells, chyle, lipids, or a combination of these substances. So if you're seeing a milky type of appearance that persists after centrifugations, this indicates the presence of chyle, which is a mix of lymph and chylomicrons. So the cause of this is some kind of obstruction or damage to the lymphatic system. And in the pleural cavity, it could be caused by certain types of tumors or trauma during surgery. When patients have some kind of chronic condition, such as rheumatoid arthritis, it can mimic the appearance of that milky chylous effusion. However, because of their constant breakdown of cellular components, it looks similar visually, macroscopically. So you have to determine the difference between those two, and really the difference is the high triglyceride or fat content of the chylous effusions, where in the pseudochylous ones, they are low or you don't see any. The visual appearance of some of the serous fluids. Now again, a bloody fluid can be seen, definitely if it's a traumatic tap. So just like CSF, we have to determine if the procedure is causing the creation of the blood or if it's actually a disease process and blood is entering. Now in the middle, the chylous effusion is definitely that milky white, high fat content type of specimen. And the last one is a pleural transudate where it's clear, it's pale, and found in systemic types of diseases. Now, if it was a pleural exudate, you would see that this specimen would be cloudier. Now, what is commonly ordered on these types of fluids? Usually you're going to get a total cell count, as well as cytology studies, identification of any crystals if present, and microbiology studies. With the total cell counts of pleural, pericardial, and peritoneal are, and when we're looking at the results of our total counts, it can help determine which way our effusions are going to help the physician classify them. So usually with your white cell counts that are less than 1,000 cells per microliter, this may help classify them into a transudate category. Whereas if you see greater than 1,000 microliters of white blood cells, you may classify this into an exudate type of category. As well as red blood cells in the fluid, you want to definitely differentiate between a bloody procedure from an actual disease process. So from a bloody procedure, red blood cells decrease the longer you get the collection, and there may not be any clots forming or small forming clots. With the hemorrhagic effusion, you're going to see that there's blood evenly distributed between each of the specimens coming into the lab. Now, physicians will also include a chemical examination or analysis of these fluids because it helps confirm the diagnosis and the cause of the effusion, as well as the appropriate treatment needed for further testing. So this can help determine a malignancy or a systemic kind of disease or an infectious type of disease. So the possible chemistry tests include total proteins, glucose, lipids, lactate dehydrogenase. And we'll talk about the ones that are important in determining those differing categories. Now, historically, fluids of transudate or exudates were classified by their total protein content or the specific gravity of the fluid alone. So, a better discriminator was needed because there is an overlap between these types of fluids. So useful tests in classifying this transudate from an exudate will be a serum and serous fluid total protein concentration in addition to a lactate dehydrogenase. Now from these values, a fluid to serum total protein ratio and the lactate dehydrogenase fluid to serum ratio can also be determined. And these ratios provide a means to diagnose a transudate from an exudate. So here are some values. So if it's less than 0.5 from this total protein, it is a transudate. Greater than 0.5, an exudate. In addition, similarly with the LD ratio from fluid to serum, if you have less than 0.6, you have a transudate, and a greater than 0.6 would be an exudate. Now, glucose has also been used to identify the differences between the two, but really clinicians are only looking to see a low fluid glucose, which is significant in a disease process, such as rheumatoid arthritis or bacterial infections, tuberculosis. More chemical analysis, such as amylase, is used to identify the origin of the fluid that's happening. So if you have an amylase value 1.5 to 2 times higher than the serum value, this is considered abnormal and has been seen in certain effusions of pancreatitis, some kind of rupture in the esophagus, any kind of gastric or perforation, which means puncturing of that, or any type of metastatic disease in this process. Lipids are also tested to identify if it's a true chylous effusion, and a cholesterol level can be done, and a fluid to serum ratio can be done as well to determine between a pseudochylous and a true chylous effusion, and helping to identify a transudate from an exudate. Now the pH is helpful when identifying patients with some kind of peripneumonic effusion or an exudate caused by pneumonia or some kind of lung abscess that requires definitely an aggressive type of treatment. And CEA is a tumor marker to determine if there's any kind of metastases happening in the body. As many causes of effusions are due to some kind of infectious process, microbiological examination is very important for identifying the causative agent. So a culture would need to be performed in addition to certain types of special stains that will identify between a bacteria or tuberculosis or other types of fungal stains.